want to thank you all for attending tonight. I'm Ian Campbell with TendoNova. Just a couple of housekeeping items. First, please keep your microphones muted. I think that's going to happen automatically. And don't share your camera just for bandwidth. We are going to be recording this, so everybody be on your best behavior. I'll try to be on my best behavior. During the presentation, if you have a question, you can ask the question by clicking the little activities icon in the bottom right of your screen. If you click that activities icon, you get a Q&A. If you type in your question there, we'll get to those at the end of the presentation. Let's see, I think that was it. We'll get to those questions at the end. We're very excited to have Dr. Greg Kolovich join us tonight. He's a world-renowned hand surgeon, engineer, inventor, entrepreneur, philanthropist. I'm probably leaving a bunch of stuff out. Just an all-around good guy. When he's not inventing new micro X-ray technology or performing surgeries near his home in Savannah, you might find Dr. Kolovich in the jungles of Honduras or in the actual Savannah of Africa, helping out needy folks restore critical hand, wrist, and elbow functionality through his nonprofit work. Dr. Kolovich earned an electrical engineering degree from Georgia Tech. That's a pretty tough school, I've heard. Then he went and earned an MD from Ohio State, and he did his fellowship in hand and microsurgery at Harvard Medical School. Above all else, I've found Dr. Kolovich to just be an incredibly curious guy. He's always willing to invest time to learn new techniques, learn about new technologies that he can leverage to help his patients. Sometimes he invents those new technologies, and he's going to tell us about TendoNova today. So Dr. Kolovich, without further ado, I'll turn it over to you, let you share your screen, and we can get started here.
All right. Well, thank you, Ian. I'm just a regular guy, but I'm really happy to be talking about TendoNova because this is a really cool device, and I'm gonna show you why. So again, Ian, thank you for that. You guys know who I am. I do have some disclosures. Of course, I am a consultant for TendoNova and some others, but really, what I'm here tonight is to tell you. We're going to talk about TendoNova, but I really want to talk about just using walant surgery, wide awake, local anesthesia, no tourniquet, and using high-frequency procedures in a low-cost, high-yield setting. I have a multi-specialty group. We're a completely private practice, so we're always fighting over OR time. And I'm always of the mind that the joint surgeons and the spine surgeons should be in there doing procedures, and I should be doing my high-volume stuff outside of the OR. And I want to explain why. So I typically don't put up a fight when my spine surgeon wants to do an ACDF or my joint surgeon wants to do a total knee. I find it's best if they use all the resources we have to do those bigger procedures, and I'll do my smaller procedures in the procedure room down the hall. And I think you should too after seeing this. So we want to talk about medical waste, unnecessary workup costs. It costs me a lot of money to get someone ready for general anesthesia. We have to pay our nurse to work them up. We have to consult our our anesthesiologist, who we pay to do workups, to say whether they can or cannot get general anesthesia. So that's a cost that we inherit as a private practice. So under local, you don't need that. There's no risk for anesthesia. You're doing under local, so you don't have to do that big workup cost. Cases don't get denied because they're too sick. You can do a lot of procedures on needy people under local, just because it's safe and easy. I want you to understand the opportunity cost. It's very expensive for me to be doing a procedure in a main OR with the help of anesthesiologists or AAs or even nurses. All that stuff adds inherent cost. And when you add it all up, like these are hundreds of thousands of dollars that can be saved. We're going to talk about TendoNova, and we're going to look at the cost reimbursement of TendoNova, which I think is really, really exciting, and you should be excited about too. It's a lot more than you think. And then hopefully you can take all this knowledge to develop your own algorithm for treating high-frequency, low-risk hand cases. So TendoNova is a really cool company that I was introduced to, and they developed the Ocelot Nano, which is this device that has a disposable unit on the right. This is the center slide, and then it has this rechargeable battery RDU on the left. And really what you do is this is completely sterilizable. The needle is sterilizable. It's cannulated. So after you do your percutaneous debridement, I like to add PRP, which I think is really, really helping my cases helping my patients get better quicker. So I really do like the fact that you can do the debridement percutaneously, as you've seen in that little video on the right. It can debride soft tissue really easy. You can also debride calcific tendonitis. I can debride the lateral condyle. I mean, this little needle is really, really strong, really durable. I have not had any needles break off. I was worried about that. And by the way, if you guys as surgeons are worrying about things, please ask those questions. I put sort of those worries to rest. I'm very conservative when I use a new device. I don't want anyone to get hurt. And I was a little worried that thing would break off and I'd be fishing it out. I have not had that happen. This is extremely durable, extremely user-friendly. It does not break down or shut down in the OR. I just think it's really exceeded my expectations this far. So this is sort of a typical case. I do it under local. The patient is wide awake. I use this sort of cheap field sterility pack. The head, you can see, is literally looking at me. I bring in the ultrasound. I do have a handheld ultrasound, but that typically gets used by my PAs in clinic. So I use this. This is the ultrasound that they use for regional blocks. So I just wheel it into the OR after they do a block. You've got 4 or 5 of them. I think every ASC has something like this, but it's just a regular sinusite ultrasound. And after I do my debridement, which we'll show you a little video of, I really like injecting PRP. PRP adds a lot of benefits, growth factors. I can go on and on about that. I was not a believer in PRP until I started using it. I think it works really well for tendinopathies. It's like a long-lasting steroid injection for arthritis, but for tendinopathies, it really does have, and you'll see that. Don't believe me. I mean, just look at the research. Even the AOS is coming out for the first time saying about the efficacy of PRP. This is a busy slide. We put this on here just to show you that everybody has a different algorithm for treating tendinopathies. And I'm going to specifically talk about tennis elbow because it's the most common tendinopathy that I see in my practice. Everybody's different. I was at the Hand Society. I got into sort of a dueling discourse with a French surgeon who, every time you talk to Europeans, it's always pretty exciting. They have different algorithms and you learn a lot. Her algorithm is very different than mine, but my algorithm is very simple. And essentially, if you come in and you meet me for the first time and you've never had therapy or an injection, I offer you stretching exercises at home or a therapy program, plus or minus an injection. Some people are really, really against injections. So just a little home exercise program, plus or minus controlled therapy with an injection. Most people opt for the injection. I find that the people that just do therapy, I would say more than 50% come back with very little relief, even ones that are really doing it. 75% of those that get a steroid injection, I pepper the bone a little bit, and I do the steroid. 75% of people really do get better after a steroid injection. And I don't think you're healing the tendon. I think you're just sort of disrupting that pain chain, that reflex, and I think it just goes away. As we all know, tennis elbow will go away with time. It can take 2 to 3 years, but it will go away. So sometimes, as I learned from my mentors up at Jesse Jupiter, always tell me to have patients live with their infirmary, and eventually they'll wear themselves out. Sometimes we do procedures to distract them from their own infirmary. But in this case, I would say about 75% of patients do well with just OT and a steroid injection. And this is really not a treatment that I would use as a first line. I think it's a great treatment, but everybody has those patients that come back after one injection or therapy, or even a procedure that went wrong, and they need another option. And a lot of people really do not want surgery. So you have to offer them a treatment between therapy and a steroid versus surgery. And I think surgery works. I go and I debride it. If there's a spur, I take it off. I put an anchor in there. I debride all the tendon. It's not a super, satisfying procedure, but you kind of just, I go in with the beaver blade and I sort of debride all the tendon that looks odd or off or frayed. There typically isn't that large hair that you see. You never see that, even though the MRI says there's a large tear. You never really see a hole, but you see tendon that just looks off. You debride it and then you reattach it with an anchor. Some people go ahead and just debride it and release it. I'm a fan of repairing it. But either way, I think my general algorithm is come in first time you get an injection. If you fail therapy and injection, I offer you another injection. They usually don't want to go to therapy or a TendoNova procedure. I rarely offer surgery. So I'm just going to show you a quick video of the procedure. You can see the guy's wide awake. This is in my local room, believe it or not. It's a lot tighter than it looks. This is not a main OR. So you can see I'm just numbing them up. I'm actually getting I'm really numbing up the periosteum. And I've done a skin wheel. They say that that can sometimes affect the PRP. So I try not to do that in isolated PRP. But because I'm debriding the tendon, I think it really gives me a way to go in and find the ECRB. Right there, you can kind of see the needle. I'm debriding it. I debride it from the top, as you can see here, and I also debride it from the bottom. I get both sides of it. This whole procedure takes about 5 minutes. The guy doesn't feel anything. I've numbed him up. He's actually talking to me. He's leaning over and sort of looking at me as I do it. You can do this with gowns and gloves. I showed that for this case because I know this would be broadcasted all over, and I didn't want to shock anybody. But I've actually done this with field sterility. I really do enjoy doing it with field sterility and just sterile gloves. It's a lot easier. It's far cheaper. But just for shock purposes, I did drape this out as a traditional carpal tunnel would be. But you're going to see that when we show the research in Walant, that all of this stuff is not necessary. It does not improve infection rate. It does not improve results. But I did this as sort of a way to show what a standard OR would look like. All right, so we'll go to the next slide. Okay, so what are my results? 15 cases. I started using this. I had a slow ramp up speed as I was learning I was getting patients to know about it. You know how things are. You have to introduce a product and then it sort of ramps up and then it just completely explodes. But in less than a year, I've done 15 cases. I've had no infections. These were all done under local, wide awake. And now 5 out of 15 at 2 weeks presented with no pain, full motion, and some weakness. I find that shocked me a little bit. It was hard for me to believe that they had no pain. But again, I was going on what they told me, and 5 out of 15 said no pain at 2 weeks. I don't think that you'll find that's a typical result. Maybe they were just trying to impress me. But this is what really impressed me, was the 14 out of 15 patients at 6 weeks that experienced absolutely no pain, no weakness, and full motion. Now, I went back and asked them, and I know you guys may not believe this, but I have videos showing all of this. Because my typical experience for open debridement with reattachment was that at 6 weeks, they still hurt. So for surgery, they always hurt at that 6 weeks. It was a 3-month mark where they came and said, I have no pain, full motion, no weakness. So if you remember anything from this lecture, remember that the recovery in my hands and in my early case of TendoNova went from 12 weeks to 6 weeks. It dropped in half. And of course, everyone at 3 months was no pain, full motion, no weakness. So again, what really jumped out, and I was telling Ian, I was telling Jonathan, and all the wonderful creators of TendoNova, is that the one thing I'm seeing is that at that 6 week mark, they typically have no pain, full motion, almost all of them. And to be fair, that 1 out of 15, I couldn't put him in there because he said he had very mild pain, but he didn't say he had no pain. So 15 out of 15 had mild to no pain. 14 out of 15 had no pain, just to be fair. So I'm just going to give you 2 typical cases. One is 66-year-old female. You guys are, if you do hand surgery, you might notice that there's a lot of people out there doing injections for tennis elbow. It's very easy to do. There's a lot of non-op surgeons that do it, which I think is great. It's so common. It scales. Tendonitis. I'm just talking about lateral condylitis. Is just so. I've had it myself. You guys probably had it yourself. It's just very common. So I had a 66-year-old lady who came to me for second opinion takeover care. She failed 2 prior injections with some therapy, of course. She came to me looking for an answer, did not want surgery, and then heard that I would do something different than surgery, but not an injection. That's what she said, quote. So I said, well, what about TendoNova? I introduced it to her, talked her into it. This was one of my first cases. I think it might have been my first case. I did add the PRP because, like I said, I really would encourage you to go do your research on PRP. Offline, I can provide you a lot of information on that. I just think it's wonderful for tendinopathies. I really do. And the research is coming out showing it is. So at 2 weeks, she had mild pain with some moderate weakness. And at 6 weeks, again, no pain, no weakness, and was extremely happy. I see her back in February. I see her on the schedule, and I'm thinking, oh, God, maybe it didn't work. No, she has a new problem. This time she's got lateral epicondylitis. I debrided her medial epicondylitis, which is very easy to do because I use an ultrasound. There's no worry about hitting the medial antebrachiocutaneous nerve. There's no worry about hitting the ulnar nerve. I'm staring at it with an ultrasound, so it's safe. And she's watching the ultrasound, so she can clearly see that I'm looking out for the nerves as I do it. So it's very safe to do the ultrasound for medial epicondylitis if you're worried about it. But she comes in at February with the new problem. I was like relieved because I didn't want to have a failure of my first case. So this is a case where I was going to jump straight to a TendoNova and say, look, you did well with the medial epicondyle. Let's just do a TendoNova and lateral epicondyle. But I wanted to be really fair, and I really wanted to do my sort of own controlled study. So I did not offer her TendoNova for lateral epicondylitis. I did my traditional treatment algorithm, which is very conservative. Okay, we're going to do OT. She failed OT, of course, came back 3 months later, did not get any better. 2 months later, did not get any better. Was actually a little bit frustrated. She was actually frustrated that I did send her to OT. So this time I gave her a steroid injection. She was open to that. I also gave her some more OT. And this woman is extremely honest. And she said, that did not help. Can we do the procedure that you did last year? So I did the TendoNova with PRP. And she did, so far, I saw her today actually in clinic. She said she had some mild pain, some moderate weakness. She said her recovery for lateral epicondylitis is the same way she recovered from medial epicondylitis. Now, there might be some confirmation bias there. Of course, she had the procedure. But again, I wanted to show you her journey because I did not offer her a TendoNova immediately. I did give her a fair chance of treating this without TendoNova. But she ended up getting a TendoNova for lateral epicondylitis, and so far it's done great. And I anticipate in 4 weeks she'll come back similar to her 6-week recovery in her first procedure. So this is really what you're going to see. This is these 14 out of 15 patients at 6 weeks. And this is really what sold it to me. Again, if you remember anything from this presentation, remember these patients typically, almost all of them come in with mild to no pain. All of them will come in my experience, have come in with mild to no pain at 6 weeks with full motion. So here, this is a 75-year-old. 75-year-old gentleman. He is 2 months out. We did a TendoNova procedure. He had chronic lateral epicondylitis. So we used the TendoNova. We did a ultrasound guided debridement, and then we injected PRP. So 2 months out. How you doing, man?
I'm doing great.
Any pain?
I don't feel no pain at all now.
How's your motion?
My motion is good. Now I can lift weights with my arm again. Before I couldn't do it. So, but it's doing great now.
So what do you think of the TendoNova procedure?
I think it's a great procedure.
Can you show me your motion? And you have no pain on the elbow anymore?
No, nothing whatsoever.
And there you go, 2 months out from TendoNova with PRP. So far, great results. Thank you, 75-year-old gentleman. What we're doing is, first of all, I'm going to follow all these patients and pretty much write it up. And I'm going to compare it to an old cohort with my steroid injections and my surgeries to really get a good look. I know you guys don't. I know I go through all the lectures too, and people show anecdotal evidence, and I know it's not worth a lot, but to me, it is, because I've been doing this for 10 years, hundreds and hundreds of thousands of injections and hundreds of surgeries, plus or minus some PRP. And I can tell you that at 6 weeks, they really do have that turning point, that inflection point where they really have no pain, which is just getting them where they want to be quicker. And that's the one thing that jumped off the page. So how much does this reimburse? What can this do for you? So I just took 2 cases that I typically do this on, workers' comp and Blue Cross Blue Shield. We have I see a lot of these workers' comp, and workers' comp are always sort of hard to deal with because they never want to get better. But these patients actually are, these workers' comp patients are in that cohort that I showed you, and they did admit to getting better, which is shocking because a lot of people, if you do workers' comp, you notice they never admit to getting better, because why would you? You could get paid to be off work. But this is a situation where I've actually had 4 or 5 workers' comp patients admit to my face that they were completely good without pain. So that was exciting to see as well. So I did not put in the 0232T code. That's a PRP. That code is not always recognized by commercial payers, and it can actually hold up your entire reimbursement of the case. So for some payers, like workers' comp, they always pay for it. Blue Cross Blue Shield typically does not pay for it. Sometimes they do. And TRICARE, which is military, does pay for it. So those are really only 2 that I add. The other I would suggest don't even put it in, because if you put the 0232 code, 0232T code, it's going to get kicked back and it'll hold up your case. If you want to know what the cost of a PRP is, the tube itself, we have a centrifuge. The tube itself, we get it from ProGen, is about $85. So you can see that $85 should be well covered from the $6,500 you're getting in the facility reimbursement. So just that workers' comp and Blue Cross Blue Shield, just these 2. The high workers' comp, this is the percutaneous tenotomy, and this is the ultrasound. You're getting a facility reimbursement for the ultrasound. You're getting a CPT code for the percutaneous tenotomy, and you only get a physician's reimbursement for percutaneous trauma. You cannot get a physician's reimbursement for the ultrasound. But the supply cost is the field sterility pack. I did not show it in the video. You just use a field sterility pack because it's cheaper. And the TendoNova procedure, that disposable unit with the needle, is $650. Believe it or not, that's by far the cheapest on the market. The competitors run over 1,000, or really close to 1,000 actually. And the setup is a lot. I don't need to tell you the setup for the TendoNova is simple. It's sterilizable, and the needle's sterile, and you just put a bag over the battery. The setup for some of the competitors is a little bit more complicated. I would encourage you to look into that to see the difference. That was also a big selling point for me, is that it was really, really easy to set up. So all in all, the total reimbursement for workers' comp is about $7,500. For Blue Cross Blue Shield is about $5,000 for an average of $6,200. Not bad for a 5 to 10 minute local procedure. So I looked at my payers. I have a heavy workers' comp, commercial insurance, heavy TRICARE. So I'm very lucky in that regard. So if you weight all my payers and you look at reimbursements, if you do about 20 cases, I've done 15, but just let's say you're just low frequency, you're 20 a year at an average reimbursement of $6,281. Based on this is just an average, probably skewed a little bit more heavy towards workers' comp and commercial payer, but I had to go what I have. It's going to yield you about $116,000. Now, mind you, that's probably a little bit high because I don't see a ton of Medicare and Medicaid, but all in all, about $116,000, and that's for 20 cases. So that's doing a little over 1.5 a month. 5-minute procedures, 20 a year will yield you about $116,000 in your practice. I'm just going to shift gears and talk about walant. I really do want to hammer home the point of playing to your strengths. The strengths of hand surgery is you guys have the incredible ability to do local cases. You can do field blocks, you can do local blocks, you can do carpal tunnel blocks, radial blocks, ulnar nerve blocks. You can get that patient numb, which means you don't need a ton of workup. You don't need the added cost of anesthesia. That really, really eats into our overhead, paying the anesthesiologist. I have a 25-person group, or multi-specialty orthopedic group in Southern Georgia, and we're not getting paid more and more to do surgery. We're getting paid less. So the only thing we can control is our opportunity cost, which I'll talk about later, and our cost of goods. So walant is huge because it can really, really drop your cost of goods. So there's two main advantages of walant. This is wide awake, local anesthesia, no tourniquet. Patient specific, they don't have any nausea. It's cheaper, we know that. You can talk to them while you do the procedure. They can actually see that you're doing the procedure, which gives them that intraoperative affirmation. And I believe that's important in establishing trust. That patient's going to remember that procedure. They're going to see the ultrasound. They're going to hear the sounds and sights of the OR. And they're going to think, wow, this surgeon really went all out for me. They did what they said they were going to do. And I think that's very important in establishing trust. Surgeon specific. So why do I like it? Well, I think you don't get any letdown. And this is not just for TendoNova, but for carpal tunnels. I do distal radiuses under walant. I'll do trigger fingers. I'll do tendon, tendonitis and repairs, all that kind of stuff. When you don't use a tourniquet, you have less. You don't have any tourniquet pain, or when you let the tourniquet down, you don't have any. I think you get less swelling, less bleeding. I think it's far easier to do skin closure because everything's sort of clotted off by the time it's ready to close. I really can have them flex and extend their fingers and look at the tension if I'm doing a tendon transfer or a tendon repair, or if I'm doing a tendonitis. I can really have them help me break up the scar tissue. And I really do get a good appreciation for the intraoperative assessment of movement. In this case, I can actually have them extend their wrists and really sort of show me the ECRB on the ultrasound. And I really do think it's very helpful for the surgeon as well. So I hypothesized when I wanted to see if walant, just local procedures, were safer, they were cheaper, did they produce less waste, were we giving less pain, less opioid use, were they getting them back to work? This is really important. I have a high yield, I have a high volume of TRICARE, which are active military and workers' comp, so they need to get back to work. Are we keeping them in the hospital longer? I don't keep anyone in the hospital, so I knew that was going to be, show that there's a difference. And ultimately, were we having fewer complications, less infections? So I just kind of went in to look at all this stuff for you. I did the exhausting sort of literature review. And if you want to know if doing a local procedure, for those of you that have some sort of anxiety about doing local anesthesia, I would tell you, like, just drop it now. I mean, this is really, I do most of my procedures under local, under walant. It has really made my practice way more efficient. The patients actually like it. I actually thought that I would be torturing them, but believe it or not, McKnight et al. In 2022 looked at over 1,000 patients, and these are patients that are getting literally injected with a needle by the surgeon, not some strange anesthesiologist or PA. I go to them, I see them, I talk to them, I do a slow injection, I get them numb, and 91% would recommend it to a friend or family, with 99% saying it is better or the same as an office dental visit, which I think is a really, really good experience for the patient. Most of my patients say they enjoy it. They have less anxiety. They really, really do get anxious about general anesthesia, obviously, because some people don't wake up. It's rare, but it happens. They compared, this was my friend Don Lalonde, his paper. They looked at walant versus general anesthesia, and they showed there was no difference in intraoperative anxiety, but the patients had a lower pre-op anxiety, which makes sense because you're there. They know you. They don't know the anesthesiologist, but you're there. You're talking them through. I do spend a good bit of time talking them through the injection to make sure that they're comfortable. And with the time that I spend there, I make up for in the OR. So is it safer? My friend Nick Jagodinsky from the UK looked at this in 2017. I went to Africa with him. He's a really good guy. He looked at 2,000 carpal tunnel releases. I do all my carpal tunnels under local. The infection rate was less than 1%, 0.4%, which is right on par for regional anesthesia. It's actually a little less. The JHS paper in 2010 said the infection rate was 0.58%, so it was actually a little bit lower. It was not statistically significant though. As far as another study in 2021, a little bit later, again, really small infection rate, less than 1%. So it is safe. I would say it's as safe, if not safer, without statistical significance than general anesthesia with a main OR in a regional block. So I typically use a small little field sterility pack. The video you saw, I prepped it out just for shock value. I knew we were draping that, but I typically use a little field dressing. Sorry. So we looked at field sterility gown, and I wanted to see that because we're not doing the whole gamut of the extremity drapes and the U drapes and prepping everything out with all the special gowns and everything, if just using sterile gloves and a field sterility, were we getting more infections? And truth is, in 1,500 carpal tunnels done with field sterility, the infection rate was actually slightly less than 0.4%. So Mohs procedure, dermatologists have been doing this for years, over 20,000 Mohs. Infection rates are still minuscule, less than 1%. Is it cheaper? Well, of course, we know it's cheaper, but I needed to prove that. And I just looked at field sterility packs, and one institution, McKnight, found that it saved over $65,000 a year. So if you add that to the $116,000 that you're getting and doing the cases, and you're subtracting 65, that's a good way to add to your margins. You're decreasing your cost of goods and you're increasing your revenue. That's a good move for you and your group. And the other thing too is we talked about preoperative testing. Well, we have to pay for the preoperative testing, and that's an average of about $858. I actually didn't know that. I thought we farmed that out, and I found out we were actually paying for that. So that was a little bit concerning. So you don't have to do a preoperative workup with a chest X-ray and an EKG for a local procedure. So that really saved a lot of time. If someone wanted a TendoNova, I could literally put them on the next day because I don't need all of this workup. And if you look at Chatterjee's article in 2011, he looked at an in-office carpal tunnel, gave about almost $1,200 in profit, where a main hospital was losing $650 for obvious reasons. High cost of goods, inefficient. You're just doing all the wrong things in terms of making money. You have to be in and out. So they actually, really good article here. So they actually look at opportunity cost in the main OR, and they found that by doing a 15-minute, I'll come back to this later, But if you take 15 minutes to do a procedure, your opportunity cost of taking that away from, say, a spine surgeon or joint surgeon is about $3,300 per 15 minutes. So it's over $12,000 an hour by putting your case in the main OR versus your colleague. And remember, you can't do two surgeries in the same room. So not everybody's going to have a room. So if you have 5 ORs and you have 25 surgeons, you got to kind of fight for OR time. I would suggest that you leave the main OR and go to a procedure room. Still get paid the same. You can still bill at a facility fee, but you can do all the wonderful things that come in with walant without the need for general anesthesia and big ORs. So medical waste, again, this is a field sterility pack on the right, and that's a typical carpal. That's my friend Don Lalonde. That's him after his carpal tunnel. All that stuff I showed you in that video goes to waste. This is just a field sterility pack. And obviously, field sterility is going to save. Big Night, again, looking at this, showed that field sterility saved one institution over 16,000 kilograms of waste in a year. And we can get into all the environmental stuff, but I mean, obviously, it's a good thing to produce less waste. So lastly, I want to kind of talk about opioid use. I was worried that the patients would hurt because they didn't have general anesthesia. Well, I find that they don't. They actually, you've seen some of the videos, they're actually using less opioids than patients who underwent regional anesthesia. So compared to a MAC procedure, walant for a carpal tunnel, there was no difference in, Miller found no difference in pill usage. And then Kurtzman did a randomized controlled prospective study and actually showed that about 98% of these procedures in walant were managed without a single opioid use. So pretty exciting. And then if you look at opioid seeking from outside providers, for MAC patients, they were about 20% were seeking opioids from other providers, and about 2% for walant patients. So all in all, patients were they were more satisfied. They had the same risk for infection, and they had lower opioid use. This is just talking about getting back to work. This is for distal radius, which you can do under walant. You can see just for general anesthesia, they were missing 20 days versus about 7.8 days for walant, with a huge cost difference. The cost was far greater than in general anesthesia than it was for walant. Lastly, opportunity cost. I said it was about $3,300 for 15 minutes. The OR in Georgia is about $70 per minute. So if we're saving $65,000 a year, we're saving $70 in 15 minutes and another opportunity cost of not being in that OR. There's huge cost savings here. And we're not doing preoperative workup for $859. You can see the amount of money that you can save per year, and the marginal gain is over $200,000. And that's just for doing 20 cases. So if you add all that up in, your marginal difference is going to be about $210,000 just for 20 cases. So lastly, I always try conservative treatment. I really do. I strive for that. I think it really establishes trust. You should too. But I really do embrace reliability, repeatability, and technical simplicity. I try to do the simplest thing. It's the old Occam's razor. The answer is usually the simplest one. And this is highly reliable, as you can see from the results. It's very repeatable, and it's really simple. You really should understand the opportunity cost. People understand what they get paid, but they don't understand what they're losing. The opportunity cost is real big, and you'll understand this when you have partners that are trying to take your OR from them. If my spine surgeon wants to add an ACDF into my schedule, I say, go ahead, man. I'll just bring my cases into the procedure. And everybody wins because we all share that facility fee because we own the center. And you should step aside too. Put the big cases in the OR and put the small cases in the procedure. You should always embrace efficiency. The biggest asset we have is time. It's not money. We can't get back more time. We're only on this planet for so long. You should be trying to get home. You want to get paid for what you do. You want to get paid well, but you also want to get home to your families and your lives. So embrace efficiency and then maximize your yield. These procedures are really high yield. They're quick and they pay well. So this is a procedure where you're maximizing your efficiency by doing walant under local. You're getting them done quickly without all the need for opportunity costs and pre-op workup. And you're getting a high yield. You're getting paid $6,000 on average. And then again, early motion. I always say this, early motion yields quicker return, which creates happy patients. People want to move quicker. They don't want to get stiff. Early motion prevents all crazy things like, CRPS, RSD, less OT. They just like when they can move. They want to get back to their life. They don't want to be down forever. And lastly, I have personally seen this shorten from 3 to 6 months to 3 to 6 weeks, which is crazy. 3 weeks is a little crazy to me. I don't know if I believe those patients, but 6 weeks for sure. They're all coming to me at 6 weeks. 15 out of 15 said mild to no pain. 14 out of 15 said no pain. And they all had full motion and no strength. So don't believe me. I mean, I'm going to write this up and show you. But the biggest takeaway, other than the fact that it was cheap, not cheap, and it's a great device, but it's relatively inexpensive to use. It's repeatable, it's reliable, it can be done under wide awake local anesthesia, no tourniquet, but the patients were getting better faster. So that was my takeaway. So I want to thank you for your understanding. I know it's late. Hope you learned a lot. I'll be happy to take any questions you may have.
Thanks a lot, Dr. Kolovich. Just as a reminder, if you want to ask a question, we've got chat turned off and we've got microphones turned off, but you can click the activities button in the right-hand portion of your screen. You can select Q&A, and then you can ask a question there. And we've already got a couple of questions, so I'll just sort of go through these in the order in which we got them. Actually, first one is, so you mentioned this concept of throughput, or being able to do, I guess, more procedures per day. Could you compare walant and TendoNova to, the old way of doing things?
Sure.
In terms of like patients per day that you could actually treat.
So the problem with open tennis elbow debridement is that I traditionally book those with supine position, with all the gowns and the drapes, and I suppose you could do that under local. You probably could. It's traditionally booked on a regional block with MAC, which has you need a preoperative workup. You have to make an incision, which is anywhere from 2 to 3 centimeters. You have to dig out the ECRB. And don't get me wrong, I still think you could do that under local, but it's not traditionally done that way. Most people in my colleagues are doing this under regional anesthesia with block. The biggest problem is you go in, you debride the tendon. It's not a very satisfying procedure. You look at the tendon, there's not a giant holder that's guiding you. You're kind of looking at the tendon. On the outside, on the superior and inferior part, the tendon looks good. And that central part where it's kind of worn on the MRI is where that tendon looks off, and it looks really denuded and angiofibrotic. So that's the part where you're actually debriding that with a scalpel. You're going in, you're probably rongering off the spur there. You're creating a bony head a bony bed for healing. And then you got to put this $1,500 anchor in. And that's the part that kills you. I already told you the TendoNova is $650. That anchor to tie the tendon down to, even on a good deal with Arthrex or whatever anchor you use, you're looking at $1,000 to $1,500. So now you put that implant in, and then you got to take the tendon and tie it too, and they hurt. You chewed off a bone, you drilled a hole, you breathe the tendon. They always hurt at 2 weeks. They're never really back to the level of, they're never back to that level that you saw in that video at 6 weeks. They're always back, usually almost always back at 3 months. But the timing takes forever, and there's an inherent cost primarily from the anchor. So you do not get those margins. You may get reimbursed a little bit more, but when you draw it out, more time, more opportunity costs, more pre-operative workup. If you own the whole gamut like we do, you actually make less with doing that procedure, all things considered, than you would in this procedure.
So that procedure sounds like it takes hours versus
it doesn't take hours. No, I don't want to be. No, I don't want to say that. That's not true. You can do that in 10 to 15 minutes. You can do that in 10 to 15 minutes, but you do have to close it. My PA typically closes, so you have to add that into. Plus, it's all the prep work. Then you put a splint on because you just fixed the tendon, so that takes time. I mean, that's usually done in, let's say, 15 to 20 minutes. The TendoNova that you saw in that video is really a 5-minute procedure. Plus, there's no splint that you put on. There's no wound closure. There's no bleeding. There's no takedown. So I would say you're looking at a difference of 20 minutes to 5 minutes.
Okay, cool. You mentioned reduction in opioid prescription following a procedure, which is really hot topic these days. What RX do you prescribe for pain with walant and TendoNova? So
for walant, I think if everybody just got on the train and stopped doing it, but it's really hard. I mean, it's hard when colleagues are doing it. I give 20 pills of hydrocodone for bigger procedures. I give 10 for smaller procedures. And some patients, I say, look, just take ibuprofen or Tylenol. The carpal tunnels and trigger fingers, I typically don't give. I don't give Norco or a Percocet, unless they request it. I'm not, I am sympathetic to that. I am doing a procedure on you. And it's really that first 2 days of night pain when they're that incisional pain where you got to worry about. I do give about 5 to 10 pills of Norco, just 325 Norco for this procedure, just because I do think they hurt that night, and you are debriding their bone. I mean, it's not completely benign. You are going in and debriding the tendon, you're debriding their spur if they have one. You're creating a bony bed for healing. So they do hurt that night. So I do get them through that night with 5 to 10 pills, never more than 20.
Cool. This is a multi-part question regarding your technique with the Ocelot. So three things to think about here. How long are you treating with the Ocelot? For example, average cutting or debridement time. Do you prefer continuous cutting or shorter bursts? And then what is your approach when inserting the Ocelot, for example, parallel or perpendicular, et cetera?
Oh, sure. So you didn't see in the video, but I go sort of from the top and I go from underneath. I change the direction twice. What you find is from the top, when you get on top of the tendon on the superior aspect, right on the, and this is just for tendon, this is just for lateral condylitis. It's pretty easy to get straight down onto the bone, but I actually start underneath it when I can get that thick scar tissue on the undersurface of the ECRB. So what I do is I actually go in underneath it, like from the inferior part of it. Everything's numb, so you can just literally drive the needle straight through the skin. I have the ultrasound with me, so I'm following the needle as I go. I put the ultrasound right on the lateral condyle, and I go down, I hit the epicondyle, and then I start debriding it. And you can do this pretty continuously. That first 30 seconds of debriding you'll see in videos, it's kind of hard. You'll hear the motor kind of like, and then it kind of chews up that scar tissue, if you will, and then it becomes really like, you can hear the RPM sort of ramp up. So you're kind of like trudging through mud a little bit as you debride that scar tissue. And one thing that you'll notice as a casual observer in the OR, or if you're using it, the ease at which you can pass the needle while you're debriding it is linear to the amount of debridement that needs to be done, or I would say inversely linear. So it starts off kind of hard, and the RPMs are kind of like you're trucking through mud. And it's kind of hard to do it, and you're kind of pushing. You're actually giving it some tension. And then as you get through that scar tissue and as you debride, it gets a lot easier, and you can hear the machine just. So like, that's kind of when you know you've done enough. But you'll have the ultrasound too, so you can skip through all that thick scar tissue. And then you go from the top. I try to get that spur down there from the top. And then what's really cool is after the debridement, which literally takes 5 minutes at tops, I've already pulled their PRP. The nurse did it for me. I don't like to draw blood. I think it's challenging to do, especially when people have veins that roll. So I have a much more qualified nurse do it in pre-op while I'm waiting for them to go back. And then they have it all prepped, spun, ready to go. You put it in a centrifuge, you spin it for 12 minutes. You extract the PRP, and it's already right there on the back table. And then what's really cool is you just take the battery off of the needle. The needle's already in the spot because you have the ultrasound there. You're literally staring at the needle, the newly debrided ECRB, and then my PA or nurse handing me the PRP, and I just inject it. And what's cool is on the ultrasound, you actually see the tendon fill up. It fills up with the fluid, so you see it go black. There's like this black bubble within the ECRB. So you actually see the debridement, which you feel and you see, and then in real time, you actually see the tendon fill up with PRP. So I think if you look at some of the competitors and you know what they are, we won't say that in my name. One of the things that you can do a thorough debridement, but at the end of it, you don't have that cannulated needle in place to inject the PRP. So you have to go back and sort of blindly inject the PRP. What I like about it is it doesn't add any extra time. You literally just pulled the machine off. You got your needle in place, and they're handing you the PRP while you're just screwing it on and injecting it. So it takes zero time to add the PRP.
Excellent. And speaking of competition, I assume you use all the competing tools also. So when you're thinking about whether to use the Ocelot versus ultrasonic debridement or shockwave, or taking a patient into surgery,
yeah,
how do you make the determination to use the Ocelot?
Yeah, so I mean, you can look at it. 10x. I used 10x for a while. I did like 10x. It wasn't really anything I had. I felt like I was really I was probably overdoing it with the tendon, maybe because it felt like I was sort of power washing the tendon, and you had to have the suction on there and the water, and the setup was not entirely easy. So I felt like I've always, as you get older and you do thousands and thousands of procedures, you realize that like that old Occam's razor, the easiest thing is probably the right answer. And rather than like sort of power jet the tendon, I felt like I was getting better results with just getting in there, getting that thick tissue off of it, which really takes 5 minutes with the Ocelot. And then I really do believe the debridement part is necessary. I think of it like planting a seed. You got to sow the field, you got to aerate the field, and then you got to put the seed in. I believe those other the competitors can probably do that, but they don't have that cannulated part to actually put the seed in, which is the PRP. And again, I'm just a big believer in PRP. So and I felt like I was probably doing more than I should in terms of just the sheer power of the debridement, especially with the water. It swelled a lot, and the suction. I feel like I was just power jetting the tendon rather than simply just debriding it. So I felt like I was being way more specific. I was being less sort of brutal to the tendon and surrounding bone. And I for sure I was getting less swelling. I noticed that immediately. When these patients came in at 2 weeks, they had no swelling, none. So I felt like, and when they were started popping up one by one that they were doing better, I immediately like went back and said, wow, I was probably doing too much. So I think that hopefully that'll be your experience too. When you start doing this, you'll be like, wow, these patients are really getting better. They don't swell, they don't hurt. And maybe you'll find out one day, as I did, that those other procedures probably do a little too much and probably cause too much post-op swelling. They still probably have the results. I would assume they probably all at 3 months get well, but I felt like these patients were getting better faster.
And on the topic of PRP, what are your thoughts on using TendoNova alone versus TendoNova plus PRP?
I mean, I haven't done that yet, just because I've always been a big proponent of PRP, but I assume you'll be able to get the job done. I really don't think. I think the TendoNova is the vehicle by which to properly inject the PRP, because I think to get a good PRP. I think having a cannulated needle there really allows me to pinpoint where I need. I think you do have to debride it. I guess I don't know. I mean, I haven't done it without it. I would think the PRP would probably make your results better, but I think your results would probably be slightly worse without the PRP. But again, I mean, if you have the ability to do it, whether you like PRP or not, I mean, you have the ability to do it. And I think that's one advantage of the, and here's the thing, whether you like PRP or not, if you look at the CAGR, the growth for regenerative medicine, it's like 19%. Whether you don't like it or not, I mean, just, sometimes you're going to fall pressure. People are going to ask for it. And it's coming. The regenerative revolution is here. People ask for it all the time. Patients have never met me. They don't want surgery ever. It seems like it's hard for me to get them into surgery, even surgeries that work. Like carpal tunnel, which PRP doesn't help carpal tunnel, but they're asking for PRP for carpal tunnel, which is ridiculous. But like the word is out there. And if you're not doing it, they're going to find a chiropractor, they're going to find another surgeon or someone else or a primary care doctor that's going to do it. So I would add it to your repertoire. Whether you think it's going to add anything to your TendoNova is basically your personal view. I won't change that. I won't try to convince you. I just think you've already plowed the field. You prepped it. Why not add a seed to help it regenerate?
Yeah, it's a great analogy. I like that a lot. All right, a couple of questions, and I know we got about maybe 8 minutes left, but a couple of questions about how this integrates with your practice. One question I thought was interesting was, did you get any pushback in the OR from using those like smaller sterility packs?
Yes. Oh yeah, they think I'm crazy.
Maybe.
Oh yes, Ian.
Have you been able to convince them you're not?
Well, I think everybody should. That's why when we shot that video, I was careful. I was like, I don't want to shock everybody, but like, we can literally do these with some blue towels and just gloves, which is typically how I typically do them. But gloves cost what, $6? The drapes and everything cost about $56 all in. I think I added it, but all of those drapes, the gallons and stuff, are about $250, $300. I mean, it doesn't seem like a lot, but it adds up, man. $65,000 in one ASC a year of savings. That's $65,000. You can pay a whole new, you can pay a nurse for that. So I mean, I think if you start thinking of it that way, I've been to Africa, I've been to India, I've been to China, I've been all over Central America, South America. I mean, I've been in situations where they're doing 2 surgeries on 2 different patients at the same time, right next to each other with one anesthesiologist. So you can't really shock me. But yes, I've seen it taken to the extreme. But yeah, everyone's going to be like, you're crazy. And then you look at that's why I put all that. I mean, those studies, which you can have, I mean, Ian can share this presentation. Those are thousands of patients, thousands. One had 20,000 Mohs patients. The infection rates are below 1%. In fact, they were below the known infection rate for a carpal tunnel under regional block in a JHS study in 2010 was about 0.53%. Those numbers I gave you were 0.4%. One was 0.39%. So it's actually slightly less. I don't think that's statistically significant, but it's not unsafe. You're still you're still numbing them up. You're still doing all your prepping with ChlorPrep or Betadine, however you like to do it. You're still careful with your hands, but there's no incision. I mean, you're doing it with a needle. So why put on costly drapes when you don't need to? When there's no evidence to show that it's worse. You don't need a laminar flow room or any of that stuff. I mean, just a regular procedure room.
That's great. Thank you for that. And then the second question on that same topic was, you mentioned a little bit about how TendoNova gives you some flexibility on scheduling. So, you know, if you've got one of your partners needs the OR room for something, you know, a much more in-depth, you can yield that OR room to him and just use the procedure room. Could you just expand on that concept?
Yeah. So in private practice, we all share the same overhead. We all share the same cost of goods. When, you know, we bring on new administrators, we all have to pay them. You know, everybody feels the cost of, we call it overhead. The only thing going forward that we can control as surgeons, we can go to Washington, D.C. and lobby all we want. We are not going to get paid more than we are today. It will get paid less. And we have shown this is the only field in medicine where you're doing better work with better outcomes, you're getting paid less. And everyone's barking about how doctors make too much money, blah, 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 blah. We work our butts off and we're getting paid less and our outcomes are better. Name me any other field in the world where those 3 things exist. So with that said, I'm not going to complain about it because I can't change it. So the only thing I can control is my cost of goods. So if I'm getting paid the same or less, the only way I can make more money is either do more procedures or pay less for the procedure that I get. This does both. It does both. So I showed you in that last slide, I think I was generating about $210,000 a year in marginal difference for the increased revenue and the decreased cost. You add that together, it's the same. It doesn't matter how you make money. One really good way of making money is pay less. That's a great way of making money. So drop your overhead. It looks the same. It's still money to you. But I think what I really like about this is, yeah, if my partner wants to throw on an ACDF and I've got 3 TendoNova patients, I'm going to slide over and do it in the local room because it's cheaper under field block and field sterility. And then that surgeon can do an $80,000 ACDF, which we all succeed when that person does it. Yeah. So I mean, like, work smarter, not harder. Work efficiently. You can cry to the government all you want. They're not going to pay you more. I promise. They're going to pay you less. So the only thing we can control, and you can't hammer these reps. They're making these things like cheaper and cheaper and cheaper and better. But you can hammer your cost of goods, which is an inherent cost. You try to use less costly things.
Have you seen TendoNova work the other way, meaning as sort of a gap filler where you've got an empty room that's, you know, just eating into your overhead and you're able to get patients?
Yeah. Oh, yeah. So one thing, Ian, that you can find is those reports where you can look at the other way too. So you look at cost utilization, OR usage. You really want to show that you're using these ORs are not sitting empty. And that plays, I don't want to get into politics of how ORs are run, But if you, what's called a CIN certificate or CON certificate of need, when you try to get another OR, let's say we petition the state of Georgia for another OR, we could use 3 ORs if we wanted to. The first thing they're going to say is, why do you need another OR? And we're like, well, we have 4 ORs and they're used readily and we don't have any more room. They're going to say, they're going to go and they're going to audit you and they're going to look at your usage in the OR. And if your usage is like 40% or it's below that, in some cases it's like 20% in some main hospitals, ours are 85%. So when you show that your usage of your OR from 7 to 5 is 85%, even if they don't care what procedure's done there. If you're doing a little trigger finger, it doesn't matter. So if the OR is available and no one's there, do it in the OR because you want to get your utilization up. So then you could go to the state of Georgia and say, look at our utilization, it's really high. And then hopefully maybe then you could get a certificate of need where you can build another OR. But you make no mistake, you cannot build an OR without a certificate of need. So the only way you're going to get a certificate of need is to prove it to the government that you deserve one, and you need to do that through utilization.
Awesome. Why don't we wrap up on that one? That was really good Q&A session. Appreciate all the questions. Appreciate all the attendees. Again, this has been recorded, so we're going to go share this with everyone that signed up for the webinar. Please share it with everyone you feel like sharing it with. And thank you, Dr. Kolovich, for an awesome topic, awesome discussion, awesome Q&A. And we'll talk soon.
Thank you, guys.